Hello, everyone. Welcome. Thanks for being here this afternoon or evening, depending on, or any other time of day, depending on where you are. I'm just going to wait 1 minute to get started because we have a lot of great questions and content today. So I don't want to waste any time, but I want to give everyone a moment to jump in from the waiting room if they stepped away from their computer. And just to introduce myself, I guess I should say, my name is Ellen Hostetler. I'm with the John Ritter Foundation for Aortic Health. I'm our Chief Science Officer, and I'm really pleased today to have Dr. Prakash with us. So I know there was a lot of interest in this topic. There always is. We are really excited to hear some of the results and data that have come out of the research he's been doing for the past year. So thank you all for sending your questions in and engaging with us and being here today. And I'm just going to turn the chat on so that everyone can talk to each other. So if you'd like to introduce yourself, say where you're from or anything like that, please feel free to do that in the chat. And then there's also a separate Q&A, so you can ask your questions there. There's an option to remain anonymous if you'd like. And we'll get to as many of them as we can. And I also have the ones that you all sent in ahead of time. So we'll get to those as well. Hopefully we can see this.
Yes.
Okay, so it looks like we have a good number of people here, so I'll go ahead and get started. So as you all know, we're talking today about exercise after aortic dissections, and the Q&A, as I mentioned, please put all your questions in there. This will be recorded and will be available if you'd like to send it to someone else, share it with another person who's living with aortic disease, or just view it again yourself. And the chat, as I mentioned, is open, so feel free to say hi and, of course, be kind to others. And then thank you for being here. So I'm not going to read this full disclaimer, but this is on our website under our medical disclaimer, and it will be on the YouTube recording disclaimer as well. And essentially, that just means that we're all here today for educational and informational purposes, and that you shouldn't make medical decisions or change your medical care based on what you learn in this webinar, and to please work with your aortic care team on any changes or decisions around your medical care and your aortic care. You can always feel free to reach out to us if you have questions about the content. And we also have Bella Marin, who's our patient and advocacy coordinator, here today in the chat. So she may jump in and answer some things as well. And we'll be happy to have you email her directly too. So finally, with that, I'll just introduce Dr. Prakash so we can get to the good stuff. And Dr. Prakash is a professor in the Department of Cardiovascular Medicine and Medical Genetics at McGovern Medical School at UT Houston. He is a cardiologist who specializes in cardiovascular and adult aortic disease. And he co-directs the Turner Syndrome Adult Comprehensive Care Center and the Multidisciplinary Aortic and Vascular Disease Clinic at Memorial Hermann. And his research interests include the genetics of bicuspid aortic valves, as well as what we are all here to talk about today, exercise in aortic dissection patients. So he's also a member of the Professional Advisory Board for the John Ritter Foundation, which we thank him for his service with and always answering so many questions and being so generous with his time and expertise. So with that, I will turn things over to him and let him get to his presentation.
Thank you so much, Ellen, and thanks to the JRF team. Of course, all of you who are our audience. Let me start the presentation here. So I would like to do several things with this brief presentation. I'll try to keep it short so we can get to a lot of questions. Feel free to interrupt me, Ellen, with any burning questions that happen during the slideshow, because I want this to be as clear as possible. I'm going to describe some of the background, how we got into studying exercise in aortic dissection survivors, some overview of the clinical trial, like what the trial was about, how we designed it, and then a few results, the preliminary results from our analysis, and then some lessons that we learned. So there are many reasons, as you all know, to recommend exercise. These are some of them, but there are many others. And it also has been shown to prolong life and improve the quality of life. That's really what we're here for, to do for all of you. And so exercise is, in fact, a very important part of planning a treatment program for aortic conditions of all kinds. There are some reasons to be concerned about exercise, which I'm sure you've also heard in various contexts. There are reports that people have had dissections during types of exercise. We have heard that the safety of exercise is not really well known for patients with all types of thoracic aortic disease because it hasn't been studied. We know that when you exercise, your blood pressure increases, and we're told that our blood pressure has to be low at all times. So it seems counterintuitive. Why is that safe? There aren't any clinical guidelines other than very basic recommendations for or against certain types of exercise. And all of this leads to a lot of anxiety and uncertainty about exercise. What is safe? What is not safe? How much can I do? And at what time can I do it? So this is where we came in. In 2022, we did a poll with JRF and with also with the Marfan Foundation about what patient priorities were living with thoracic aortic disease. Exercise questions were rated as a top priority in that poll. And specifically, 90% of people who responded to the poll felt confused or uncertain about how to exercise safely. And when we asked about whether they specifically knew about or complied with the current recommendations by the American Heart Association to do 150 minutes or more per week of moderate intensity exercise, most did not meet that threshold, so they were relatively inactive. And 80% said that coaching with an exercise expert would be helpful to help them get started, to overcome some of their concerns about exercise. So with that in mind, we were very fortunate with the support of JRF to get a grant to launch a pilot study of exercise in aortic dissection survivors. This was in 2023, and the study that I'll be talking to you about is just wrapped up this year. So it was an 18-month study. So what we proposed to do was the first ever randomized controlled clinical trial of exercise specifically in aortic dissection survivors. It was pragmatic, meaning that we let people have all their regular treatments and we just kind of layered this exercise program on top of it, going to their regular doctors, getting whatever clinical tests that they would normally get. And we did it in a multicenter format, meaning that we partnered with two other groups at the University of Michigan and at Washington University in St. Louis to enroll patients. So it wasn't just in Houston where I work. And the main endpoints of this study is were to investigate if exercise was safe in people with aortic dissections, if it could have effects on blood pressure, which we were hoping would be to lower blood pressure, and if it could improve mental health. So this is kind of the rationale that we set out for this program. First, we wanted to show that moderate intensity exercises are safe after aortic dissection. We wanted to determine whether exercise could reduce anxiety in particular, but also increase confidence to engage in exercise and other activities. We were hoping to study the reduction in systolic blood pressure and arterial stiffness that may occur in certain groups that exercise. And we really hoped that by creating a type of exercise that people could do at home, that we could expand the benefits of exercise for people who might not be able to access cardiac rehabilitation services, which are often restricted to specific groups that come out of the hospital. So the objectives of the study, again, were to measure the psychosocial impacts of exercise. We wanted participants to track their self-reported activities and time spent in the year-long study. Doing exercise and other activities that would increase their heart rate and blood pressure, and then to measure blood pressure responses to exercise and determine safety. So the enrollment criteria for this study was you had to have had a thoracic aortic dissection, either type A or type B. You could be repaired or not. So about half of our participants, as you'll see, had aortic surgery and half did not. They had to wait at least 3 months in order to enroll. And the reason for that was we did not want them to be in the acute phase of their dissection. So 90 days is typically when we say that a dissection has gone out of the acute phase and that some healing has occurred. and they had to be able to attend 2 in-person exercise training sessions at one of these 3 study sites that are shown on the map. So this was the overall design of the trial. At study visit 1, we enrolled them. They signed an informed consent form that explained, that we didn't really understand all the risks of exercise, that this could be a risky protocol, and that we and provided some answers to questions about how we were going to keep them safe. They filled out questionnaires about their exercise habits, and we did a 24-hour ambulatory blood pressure test just to measure their blood pressure at enrollment. Then they got randomized. So they were assigned either to a group that had guided exercise or a group that had usual care. The guided exercise meant the following. They had 1 in-person exercise training session at the time of enrollment. Then they had 1 virtual home check-in session where they would take the exercises home and demonstrate them in front of our video camera so that we could see that they were doing them in the same way we had trained them. And then they had 2 virtual follow-up check-ins over the course of the next 6 months, where we would reinforce some of the teaching that we had at the training session and see how they were doing. They could also fill out exercise questionnaires and diaries of their exercise each month and send them in to us. The usual care group got what we typically do for patients who are diagnosed with thoracic aortic disease. We counseled them about types of exercise that we recommend. We gave them a pamphlet that explained healthy types of exercise and activity levels. And then they went to their usual doctor visits. They didn't get any in-person training, and they didn't get any kind of home exercise programs assigned to them. And then after 12 months, they did the same thing at the final study visits, filled out the same questionnaires, and had their blood pressure checked again. So that was the 12-month program, and for each participant. And again, they were randomized 1-to-1, so we were going to have equal groups in the guided exercise and usual care. So this was the type of exercise we asked people to do in the trial. We had a circuit of 6 exercises, and these included bicep curls, wall sits, hand grips, leg raises, stationary cycling, and treadmill. And I have the details on the left side about how we designed each of these exercises. The goal was to have people in the in-person exercise demonstrate this for 2 minutes while we measured their blood pressure. And we did that by bracing their arm and measured blood pressure in their arm, in the arm opposite to the one that they were using for exercise, if they were doing bicep curls, for instance. And then we measured blood pressure in between each exercise, and we repeated the circuit twice. So the reason we chose these exercises is, one, they can be done at home with minimal equipment. They're low impact. And we developed a protocol that could be easily standardized across all of the different study sites. We did this by video. We had a training session so that everyone knew how we were going to tell the participants to do these exercises. And we observed the participants during the exercise and corrected them if we felt that they were doing something that could cause muscle or tissue damage or raise their blood pressure inappropriately. So we had guided feedback, we braced their arm, we measured the blood pressure, and the foremost aspect of this was to maintain the safety of these exercises. You'll also notice that the exercises are a mixture of what we call isometric or isotonic and aerobic, and that they also exercise different muscle groups. This was intentional because we wanted to kind of reflect a wide range of different types of exercises and intensities that people might want to do at home, and be able to measure blood pressure responses. So this was the overall outline of the study, just basically repeating what I showed you in the previous slide, where we had a recruitment period of around 6 months. Everyone spent about 12 months in the trial, and then we had a data analysis period, which we're just finishing now. And these are all the different study time points on the bottom at 1 month, 3 months, 6 months, and 9 months, where we did these check-ins that I mentioned. So this is how it went. We screened over almost 500 participants. There were almost 400 who expressed interest in joining the trial. We had an online way for people to sign up. And then when we assessed them, 180, about half of those were actually eligible based on the criteria that I mentioned. And we enrolled about half of those, 93. So you can see that we had to screen a lot of people to get a very small group, relatively speaking, to what we started with. And the reason for that is, of course, there were lots of requirements for this trial. You had to be able to go to those study visits. You had to be motivated to spend a year exercising. It wasn't for everyone, clearly. And that's something that I will refer back to when we talk about the results of the trial. So of these participants, this is the breakdown of the characteristics. You can see that the average age is in the mid to late 50s, which is consistent with what we see in aortic dissection groups that we have studied in other contexts at our different sites. We can see that about a third were female and 2/3 were male. And that, again, is consistent with a lot of dissection studies that we have done. And you can see that about 3/4 to 2/3 were type A dissections. Again, very, very consistent. And 1/4 to a third were type B dissections. Of the type A dissections, almost all of them had surgery, and about half of the type B dissections had surgery. So the majority of people had some sort of aortic surgery before they entered the study. And we had relatively few non-white participants, as you can see here. So this is the results of the completion of study visits. And as you can see, there was some attrition across the different study visits, beginning with our 93 participants. When we looked at everyone who completed all 4 of these visits and the final study visit, 65 of the 93 participants did. So we lost some data along the way. And that is one of the reasons why the study had limited power to detect some changes that we're going to talk about. So the main result was that exercise is very safe. So in all of the observed exercises and during the 12 months, we tracked any kind of adverse event. An adverse event would be having to stop an exercise, having very high blood pressure, obviously having a dissection or any other aortic complication. So there were no aortic dissections during the 12 months for any of the study participants. No one had to have an urgent aortic operation during those 12 months, and there were no deaths. There was one in-person exercise session that was temporarily paused because someone developed very high blood pressure, but that person was able to eventually complete their exercise session after their medications were adjusted by their cardiologist. 4 in-person exercises were modified because participants developed high blood pressure, but they were able to eventually complete them when we lowered the intensity of the exercises. And this was the result of the guided feedback that I described. There was one participant who had a right iliac artery dissection at home, not during exercise, just at rest. And this did not require intervention. It was monitored, and the participant was able to continue exercising. So this is the blood pressure response to exercise while we observed the participants and measured their blood pressure during steady state exercise. And what we did was tracked all of their responses to what we would consider a hypertensive response, so over 170 millimeters of mercury or over 200 millimeters, extreme hypertension. You can see that that first of all, extreme hypertension was very rare in our group. Of all the participants, there were only a handful that achieved that degree of hypertension, and most of them were during wall sits. Wall sits is a very intense isometric exercise that recruits big muscles, and it is known to cause high blood pressure. We anticipated that, and we were able to usually correct participants by lowering the degree to which they strain themselves during the wall sit, and that corrected the problem in these cases. You can see that outside of wall sits, individuals who who ran on the treadmill were next most likely to develop moderate increases in blood pressure. And this probably had to do with deconditioning and that some of our participants had not done much training prior to beginning exercise. And we did ask this at a moderate level, so it was quite challenging for people who are sedentary. So the other thing that we did was look at trends in the ambulatory blood pressure monitor, and we did see a correlation between participants who had systolic blood pressure greater than 170 during one or more exercises and what we call episodic hypertension during an ambulatory monitoring period. So on the bottom is a typical example of this. So this is a 24-hour blood pressure monitor, and the red line on this graph indicates systolic pressure, and the blue line indicates diastolic pressure. What you can see is that beginning on the left, the systolic pressure in red looks fairly normal. As the normal is that purple rectangle that you see going across the screen. But then as the individual proceeds through the day, you see these bursts of very high blood pressure up to 200 millimeters, and then going back to normal when they rest at night. So this so-called episodic hypertension is very common in people with thoracic aortic disease, and it's one of the reasons why we do use 24-hour blood pressure, because if they're at rest, their blood pressure may be normal, and at different times during the day, it can get quite elevated. And the same is true for being at rest versus being at exercise. So we do think that there is some utility in using this to kind of predict who might be at risk when they start to exercise and to control it using medications. So mental health results were a little disappointing, and I will explain why. And it's really a good reason. It's not what you think. So the way we used a scale called the PROMIS scale, which is in which a score of 50 is exactly the population average for a condition like anxiety. So if you score 50, then you are at the population average. The higher your score, the more impaired you are due to symptoms. So a score of 80 above would be very severe anxiety, for instance. And a score of 20 would be much less anxiety than normal. Okay, so when we looked at this and we looked at the baseline, you can see going across the top of the graph that at baseline, almost all of the scores were within one standard deviation of the norm. So the group of participants that we recruited for the study did not have any severe mental health issues. And this made it difficult to prove that exercise actually improved their mental health, because it was already pretty good when they started. And that is exactly what we found, that there wasn't a major change in these participants, because on average, they were doing pretty well. Now, we have yet to break out a few of the outliers to see if there was any difference in people who did have high scores to begin with, but they were relatively few. So I don't expect any major stories on this. So as I mentioned, overall, it was disappointing in that we couldn't show that mental health improved, but it was reassuring in that our participants actually were doing pretty well and were resilient in terms of their mental health, some fairly recently after dissection. So I think that is the takeaway I choose to look at from this. So we couldn't show that mental health improved, but in our preliminary data, we're looking at aortic stiffness and blood pressure, both clinic and ambulatory, and we do see a significant effect in the exercise group in blood pressure responses. Their blood pressure dropped by an average of 10 millimeters of mercury from the first to the last study visit. So that's pretty good. That's like taking a medication. And so I think that we will see some changes in blood pressure, and I'm very optimistic that we'll also see changes in aortic stiffness in the group that we measured in Houston, but we haven't looked at that data yet. Ultimately, what we really want to show is that would translate into fewer potential future complications in aortic disease, because your blood pressure, we know, predicts many changes in the aorta over time. So that will require a longer and larger trial. So this is the lesson. These are the main lessons that I learned so far. That exercise is safe, but we found that experience and technique matter in our guided feedback, and that we can correct many causes of elevated blood pressure during exercise by modifying technique. Observation and directed feedback in this can be very effective. Barriers to enrollment created bias and limited the power of our study, and the main barrier being the need to travel for 2 study visits and the need to maintain contact with the study team, which is very difficult when people have busy lives and a lot of medical issues. And because of this, I think that the study participants, in fact, were not very similar to many patients that we see who are struggling to get access to these services. So that is one of the main lessons, is that we need to make our study population closer to the people who really need the most help. How do we do that? We need to reach patients where they are. So we need to have a 100% home-based protocol where people never need to come into clinic. They need frequent feedback and encouragement to prevent dropout and attrition. And to do this, we'll need to have apps and wearables for data collection so that people don't have to do anything to notify us about their activities. And we need to target individuals who are unable to access rehabilitation or physical therapy services because those we know are the most at risk for complications after dissection. But we did establish infrastructure for future home exercise trials, and we learned a tremendous amount in terms of how to collect data and monitor our patients. And so we feel confident that we could overcome these barriers and make an improvement when we do the full version of the trial that we anticipate. So that's my presentation. I'd like to specially thank Alan Braverman, Kim Eagle, Marion Hoffman-Bowman, and those who are our collaborators who helped to enroll patients for this study, obviously JRF, and these are all of our study team at the University of Houston, Texas at Houston, who helped with the clinical trial. Of course, many of the patients really made this happen. Thank you.
Fantastic. Thank you. And we had a lot of good commentary in the chat during this and questions. So I think people are really engaged and we had a great turnout. So I'm really enthused. Not to make it about my questions, but I guess to just start off with the last thing you said about lessons learned and going forward, next steps, what do you envision? What do we need to answer more of these questions, to complete a trial like that? Obviously, time, research, funding, all of these things. What would be, if you had resources, what would you envision that looking like to be able to answer a lot of these questions?
Yes, I'd like to do a nationwide trial of home-based exercise that includes a lot of remote data collection and frequent kind of virtual coaching. Because one thing we really saw in the in-person coaching sessions is that feedback is invaluable. We could really correct problems when we saw them. We could answer questions and we can improve the participants' confidence. So I think without that feedback, people often get discouraged because there's a lot of negative information out there. And if you feel alone, it's very hard to kind of continue in the face of that. But with positive reinforcement, we could really see a change. And a lot of them said their attitudes about exercise had completely changed after we showed them how to exercise more safely and pointed out some ways that they could protect themselves going forward. So I think we lost that momentum because we didn't have the capacity, to engage with them continuously throughout the trial. And that's something that was a big learning point for me.
Someone commented, and I don't know if this is, an allowable thing in research actually, but that maybe having support within the group of participants themselves might also encourage people to continue participating. When you mentioned they feel alone, if they can say, hey, I did my workout today, did you do yours? Perhaps the sort of buddy accountability system. I don't know if we can match make people like that in research, but I certainly...
Yeah, there is actually an example of things like that in cardiac rehabilitation. So there are rehab groups that are home-based and they have used this model to some success. The issue, I guess one of the issues, like you said, is we would have to get people's consent. Not everyone might want to do that. And then it introduces a potential bias in the study because people who might engage are fundamentally different than those who might not. So we would certainly have to take that into account. It wouldn't be so straightforward. I do think that it could really help people though. So I'd love to find a way to do that.
Yeah. And I'll just note that there is a group called Aortic Athletes that's very active. And I know a lot of them are probably here today and participating in this research. So although it's not affiliated directly with Dr. Prakash or the JRF or research, they are a group out there who are people with aortic conditions who are still participating in athletics and sport. The biggest question that came in several forms that I'd love to have you address is, can this information be translated or generalized to people who have not had a dissection but are living with a thoracic aneurysm in the kind of watch and wait phase? And same question, but for people with specific genetic aortic conditions. We have someone with low East asking, we have several people with VEDS here. In general, some of these different specific groups, can what you've talked about be translated to them?
Yes. So we before the trial, I didn't mention this, but we also studied patients with aneurysms in the run-up to the trial to generate preliminary data. And so we studied 50 individuals that had aneurysms over a period of a year from clinic, running them through the same exercises. And again, it was safe. I think we use the same guidance in terms of the exercise. I think the main difference in the setting of a condition like Loeys Dietz or VEDS, where there is the potential for more extensive aortic disease, is to really do a thorough assessment of the participants before they start exercise and understand where they are in the course of their aortic disease, whether the treatments are optimized or not before starting, because I think that's the single biggest predictor that we found in terms of progression of disease. So if individuals have an updated assessment prior to beginning exercise, then we can feel more confident that they will do well. And I would say that's exceptionally important if you have a genetic condition.
Were there individuals with genetic conditions who were part of the intervention arm who received the exercise coaching and?
Yeah, so unfortunately, we didn't have genetic data in this trial, and part of the reason is we didn't have a lot of clinical information on many participants. So to keep it fair, we asked a minimum of questions to establish eligibility. Also, we didn't want to exclude people who didn't have that information. So not everyone, for example, had genetic testing or an evaluation, depending on where they were from, and therefore we didn't include that in our main analysis. Obviously, that's something I would love to look at and stratify by genetic diagnosis. In the larger trial, when we have more participants, where we can do that.
Okay. We had two questions about wearables, and is there anything out there already, or are there things coming to the market that would be a wearable blood pressure monitor specifically that are
Yeah.
released?
So there are several companies like Actia that have developed wearable blood pressure monitors for the market, but they're fundamentally different than the kind of blood pressure that we measure in clinic or in the 24-hour blood pressure. They use a different technology, and what they're able to do is to produce an average blood pressure reading over a period of time. Typically, over an hour, they will give you one reading, and that reading is your average blood pressure during that time. They still have to be calibrated very regularly with a blood pressure cuff, otherwise they go out of calibration and become dangerously inaccurate. I tested one myself, and it only lasted for about 10 days before it needed to be recalibrated. So the concern is that if you use those, it would be very difficult to enforce that in a large group of people who are in a trial and get precise readings. So I think we're not quite there yet in terms of, but they are very convenient and attractive because it's just a bracelet that you wear. You don't have to even think about it. But I think in 3 to 5 years, that may become a real possibility where these become precise enough to use long term.
Yeah, that would be a great addition in our arsenal. It seems like technology should be able to get that going by 5 years from now, considering everything.
Yes, I certainly hope so.
You mentioned the ambulatory blood pressure monitoring. Some folks are asking, one, can they buy this for themselves? And then, which I think you mentioned before, can be quite expensive. But two, do most cardiologists do this? Can they ask their local doctor for this kind of 24-hour testing or monitoring to see where their rhythm is falling?
Yeah, so ambulatory blood pressure is in kind of a weird transition phase. If you look at the guidelines for clinicians, for doctors, a lot of them say that they should be using ambulatory blood pressure to measure and detect hypertension. But the fact is that very few doctors currently offer that in their practice. And that comes down to one major reason, that it doesn't pay well. Unfortunately, the monitors themselves compared to the other equipment that cardiologists use are very cheap. They're not cheap in terms of an individual sense. They cost several $1,000s each, but they certainly fall within the range of other equipment. What stops people from using them is because the government currently reimburses ambulatory blood pressure far below other device costs, so that it doesn't make it worthwhile for most practices to do that. Only a few very specialized practices in most cities offer this, which is unfortunate. But we just think it's so important for aortic disease that we wanted to do that regardless.
That's unfortunate. I agree. Um, okay. We had someone ask about the standard pamphlet that you give out for for the folks that were in the control arm. Someone wanted to know if it was available, if we could send them a copy of it. I don't know if you could share that with
Yeah,
me, and I can.
sure. I mean, I'd love
Yeah.
for more people to get it. We developed it for our clinic, but it's certainly generalizable. It's for everyone with all types of aortic disease, really.
Okay, great. I can certainly share it when I share the recording, and anyone can take a look there. And if you somehow ended up here and you don't get it, reach out to us and we'll get you a copy of that. Um, okay. Someone asked about how can we monitor build up exercise intensity to a safe level besides the perceived exertion chart? Um, I'm wondering if they mean they are having trouble navigating that chart and how it applies to what they're feeling, or if they're asking about something else, but
Yeah, so what we typically recommend is that if you are starting out from doing no exercise, that you should not immediately go to moderate intensity. That it basically you need to use common sense. And if you feel like you're exhausting yourself, that's probably too much and back off. But in most cases, starting at low intensity and gradually ramping up over a course of weeks to months is the best way to go. And we recommend that people chart their activities so you can go back and look at what you did because we forget what you did a few weeks ago. And then you can also see your progress. I think that has a very positive effect when we ask the patients to do that. In the trial, many of them did comment that they could look back at their exercise logs from 2 months before and see how far they had come. So I think that gives you personal motivation to keep going because you can see the improvement too.
okay. This is a really good question that I love. And I'm sure you'll be very diplomatic, but someone said, they were given a 20-pound weight limit by their doctor. But they want to know, where does this information come from? Where did the 20 pounds, what is this based on? And I know that people in this chat, I am sure, were given many different variables of that number. I've seen anywhere between 8 pounds and no limit. I've seen people for the rest of my life. I've seen a lot of folks say that they were told for the rest of your life, your limit is, let's say, 20 pounds or whatever the thing is. So can you talk about where those numbers come from and what they mean and kind of what your opinion on limits like that are?
So the numbers do not come from any scientific rigorous study, any clinical trial. They usually they were written down by someone a long time ago and just proliferated because no one really knows the answer to that question. There is no specific weight that has been shown to be worse than any other weight, and no one can really tell you that with certainty. But it sounds better if you say a specific number because people expect that. And so I think that's a response to really human nature, where we want certainty and definability, but there may not always be that kind of certain level. And in reality, 20 pounds for let's say, a 90-pound woman is very different than 20 pounds for a 250-pound man, right? So it's kind of absurd to think that a 20-pound limit would work for everyone anyway. And how would you even figure that out? So there is, a rational way to approach the problem is to say that anything that you lift that requires straining is probably the limit you want to stay below. And that could be a very different number for different people. But to put a precise number on it defies logic, in my opinion.
Mm-hmm. I think it also goes to what you were just saying about your progress too, because if you're just starting out, the whole point is that you should be able to increase what you can safely lift
Right.
without do perform without straining. That's why we're exercising is to get stronger and fitter. So presumably, right in there, you'd want that to be able to increase over time as you practice. Okay, what else do we have here? So many folks. Can you comment on heart rate versus blood pressure? So a lot of folks have also been told keep your heart rate under a certain number during exercise, and that's safe, or that's, your limit. So can you talk about that relationship?
Yeah, so what we found in our studies is that heart rate and blood pressure are really decoupled in people with aortic disease. One can have nothing to do with another. And that the reason for that is most people who have survived a dissection are on multiple blood pressure medications. These medications affect the relationship between heart rate and blood pressure. And so you can't use the guidelines that people have developed for healthy people when you're on these medications. And also, the blood vessels themselves have fundamentally changed after dissection. So how blood pressure is regulated actually changed. And that means that guidance for exercise really needs to be individualized for people with dissection. You can't go by heart rate zones that you might have read about. They don't apply to people who do not have healthy arteries. Those were all healthy controls that they were developed for. So keep that in mind because sometimes that's unrealistic to hold yourself to that healthy standard when you're recovering from a dissection, and it may actually be harmful to try to reach those milestones.
This is a good question I haven't seen before. Is there a difference that you have observed in these changes between upper body and lower body exercises? Someone wrote in addition to that question, someone else wrote in and said they were specifically told bench press is never going to be allowed. Can I still do it at a low weight level if I'm not straining?
Yeah, so really what we saw was that blood pressure responses are proportionate to the size of the muscles that you're recruiting to do the exercise. So for example, leg exercises tend to recruit more muscles than upper body exercises. And when we saw the largest increases in exercises that require muscles below the diaphragm. Those are the largest body muscles. So it makes sense that yes, there will be different responses to leg exercises than arm exercises, simply based on the size of the muscles involved. And it will also be different in different people.
And how about, are there any that you would just categorically say never do, like the chest press, no matter what the straining level is, or a
Yeah.
different size like
So
that?
I think people have a conception that doing a bench press is going to raise your blood pressure more than, say, doing a biceps curl. But what we and others have shown is that you can raise your blood pressure to exactly the same levels doing a biceps curl as a bench press if you do them incorrectly. So really, I think the distinction is more about the technique that you're using and than it is about the specific type of weightlifting that you're doing. Certainly, it's possible to do bench presses safely at low intensity if you're paying attention to your breathing, if you're using the right technique to avoid straining, then there is no reason why it can't be as safe as a bicep curl. But you need to, I think, in that case, consider getting training to do it properly.
Can you elaborate a little bit? Someone asked about how do you know if when you've reached the straining threshold?
Yeah. So when you feel a pressure in your chest or abdomen, you are generally recruiting those abdominal muscles and increasing the pressure inside your chest. That's the point at which we define straining to occur. If you don't feel that, then you're below that threshold. And again, that will vary for different people depending on how your beginning fitness and strengths. The more strength you develop, the higher that threshold becomes.
Um, who is the best doctor to get exercise recommendations from? Cardiologist, my surgeon, a physical therapist? Who should I work with to develop a plan?
Yeah, so I think the best conversations I've had about this have been with physical therapists and experts in cardiac rehabilitation because they're used to seeing these kinds of changes in their patients and also used to helping people adapt do changes in their exercise habits after having surgery or dissection. So I think that if anyone can get rehabilitation after dissection, that is definitely a great option. What we are concerned about are the people that can't get rehabilitation services. Where can they go? And so the other thing that we're doing is actually creating a document to educate physical therapists about heritable vascular diseases so that they can make these adjustments and feel confident that they are treating the patients in a way that's consistent with these guidelines that we're trying to put together.
Amazing. I did want to add, someone wrote to me directly that they were able to get physical therapy covered under a diagnosis of deconditioning after their research. Basically, you haven't been active, you haven't been, and so their insurance actually paid for it. So I guess that's something to look into if you're based in the US and you do have insurance and you're looking for that, and you didn't get cardiac rehab, because we know unfortunately that that's not available. But sounds like that worked out for at least this one person, which would be a great way to access that. Okay. What else do we have? Okay. We have a handful of questions about really specific exercises. Is XYZ safe? And we'd probably take up the rest of the time if I asked you each individually one. So can you comment on what goes through your mind when you're asked these, and kind of how you would think through in general? That might be helpful to everybody. If they say, we have someone asking about squash, for example, which is apparently quite high intensity, pickleball, kayaking, scuba diving, all of these things. How do you answer those questions when obviously we don't have data and evidence and research on, dissection survivors who are playing squash specifically, unfortunately, yet?
Yeah, so I think the dividing line that we as cardiologists think about is contact. So how much contact is there? Are there violent collisions? Is that possible? And sudden decelerations. So what we know is that those pose the biggest risk for physical violence to the body. And when that happens, certainly the aorta can move inside the chest, and there can be some pressure on the aorta physically. So sudden decelerations, collisions, especially against hard surfaces, if that's possible, pose a significant risk. And we generally kind of draw the line there to say, if you're doing something that has that degree of risk, then you really need to think about it carefully, because it may not be worth the additional gain that you get in strength and aerobic capacity to do that exercise.
Okay. This isn't specific exercise, but I feel like it falls under this category, and it's so popular right now. Cold plunging, sauna,
Polar plunges, yes.
yeah, where I live here in Seattle, there's a whole group that goes out to the sound, rain or shine, 52 weeks a year, even right now, and gets in the sound, which is freezing. So I think it's very of the moment. There's a lot of health influencers who promote it. Do you have any thoughts on that?
Yeah, so there is evidence that sudden exposure to cold, particularly in cold and not heat, can trigger vascular changes. So an example of this is heart attacks or myocardial infarctions are known to be triggered by exposure to cold. And this has been studied in some detail. So it seems like the vessels spasm, and that appears to cause blockages to get worse. Now, if the same process were theoretically to happen in the aorta, which is a much larger artery, then yes, it could be deleterious in somebody who already has a dissection. We know that blood pressure can really increase when you expose someone to cold. And this is a stress response in that the vessels kind of clamp down in your skin to kind of conserve warmth, but that ratchets up the pressure for all the other medium and large arteries in your body. So from that perspective, we know that the pressure response is not favorable for someone with aortic disease, and therefore I would not encourage it. I don't think we have enough evidence to say it specifically causes dissections, But for those two reasons, I would be cautious about it.
It also just sounds terrible to me
It
personally.
sounds
I don't
terrible.
want to go in cold water.
I know. Yeah, that too.
I like a nice 80-degree pool myself, and I love swimming. Okay, we had a follow-up about the deceleration. So does that mean that all rides at Disney are out for our theme park lovers?
Yeah, so I mean, I really meant decelerations that can cause bodily injury, and hopefully people aren't routinely getting injured on these rides. If so, then just from a practical perspective, I would not choose that ride.
Go to that
Uh,
park, yeah.
so really that's what we're talking about, like violent collisions that occur in competition where you're going to run into a wall or run into another person. Those can be particularly traumatic. And so that's what I was talking about.
So an example like hockey where people are pushed up against the
Yeah,
board.
slamming into a wall or something where you're going full speed and then you're stopping suddenly. Yeah.
Okay. This is a great question too that we get a lot. So for someone who has a strong family history, multiple people who have had aortic dissections, but negative genetic testing, meaning that science has not yet identified what gene is responsible, although clearly in this family it is. I have no signs of aneurysm or problems with my aorta. Should certain types of exercise still be avoided?
Yeah, that's a great question because you're being screened and followed and presumably treated as if you might develop a dissection. You might be at risk, and we don't know. I think that is a very difficult question to answer because each kind of mutation and gene problem in families can be very different in terms of aortic risk.
Yeah.
So my advice would be again, thoroughly check out your aorta. If it is in fact not changing and your blood pressure is well controlled, then I think you could proceed with ramping up an exercise program the way we talked about, going gradually and frequently reassessing your risk over time. There's no easy answer here, but I do think that, not exercising, being sedentary is a bigger risk because then you're exposing yourself to the risk of developing hypertension, diabetes, other kinds of health conditions that can seriously impact your aortic health going forward.
Um, Related to the long-term effects, someone has asked about aerobic versus weightlifting, and is it enough to just do aerobic, or is it important to do some light weights as well?
Yeah, so the reason we chose all of those non-aerobic activities is because we do think, and the guidelines say that you should incorporate some resistance exercise for several reasons. One, resistance exercises actually do a great job of lowering your blood pressure in the long term. Two, they can also prevent things like bone loss, which happens as we age, and things like osteoporosis, and they're probably the most effective preventative measure against that and future fracture risk. And then also strength and frailty have been shown to be an independent predictor of survival in people with thoracic aortic disease. So the frailer you are meaning that you have low muscle mass, the more likely you are to die earlier. And that's independent of everything else we know about the aortic conditions that we study. So it is a major marker that we try to follow in patients, and exercise and specifically resistance training is the best way to prevent frailty.
Sometimes I think we can forget that we're more than just our aortas. We're all of the rest of our lives and body as well that we need to worry about and keep healthy as possible. Um, so for folks who are more active and maybe they were active before and an athlete or amateur level, someone commented that they did cardiac rehab and it was too easy. They had to ask to be challenged. So good for you. They said they're still exercising. Can I keep increasing my time and reps? Find new exercises? What's the next step for someone like that who's already doing a good level of fitness? They're meeting these recommended minutes a week for activity, for example.
Yeah, so keep in mind that those are just the minimums. So we haven't really set a maximum. We haven't told people they can exercise too much, because really it's very difficult to define a maximum for someone who's used to exercising for long periods of time. And I think if, especially if you've done that in the past, there's no reason not to keep increasing. Again, my biggest ask would be to make sure that you're getting regularly checked. Even if you feel great, keep in mind that you are changing your activity level, and that can change the way your blood vessels uh, react to your treatments. So you do need to have regular monitoring of your aortic disease during the period when you're increasing your activities.
Mhm, mhm. Do we know anything about how your blood pressure changes if you exercise for 60 minutes versus 30 minutes? Is 30 minutes automatically going to be safer, for example, if you're
Yeah. So there's actually been a lot of study on this, not in people with aortic disease, but in healthy volunteers. And it turns out the longer you exercise, the longer you get what's called post-exertional hypotension, which is where your blood pressure stays lower than it was before you started exercising. Now, if you exercise a short period of time, it lasts a very short time. But if you exercise a long period of time, it can last up to 24 hours after you stop exercising. That is, your blood pressure is measurably lower for the rest of the day. And that's really where we think the benefits of exercise when we study people long term come from. Even though your blood pressure goes up in that short time you're exercising, if you look on average, people who are highly active, their blood pressure drops over time on average. And that's what seems to make the difference for them.
Mhm. As we're approaching the hour here, I wanted to ask kind of a big picture question, which is and some people have asked you, what can we do to get more answers? What can the patient community do, or family supporters who care about this and want there to be more research and more info and more evidence-based guidelines out there to support your work and the work that other researchers are doing? How do we get this info out to physicians and other medical practitioners that see these patients? Do you have any big picture ideas or hopes that we can walk away and in our own communities maybe make an effort on?
Yeah, so I think that part of it comes from physician education. Obviously, there are lots of uncertainties in the physician community that lead to these variable recommendations. If people had a reference document, like we said, that would be the goal, is to get guidelines out there that firmly state what is possible for people with thoracic aortic disease to do. That is my goal. In order to do that, we need the randomized controlled trial data showing that exercise is safe and effective. And that is the whole motivation, or almost the entire motivation, for continuing to study this, because I really want to see that changed and get out to the community. In between, what can we do? We can promote this uh, by generating um, information that people can take to their doctors. And also, if you're interested in participating in a clinical trial, we should have a sign-up page to get people who want to study this to identify themselves, so that when it comes time to do this study, we'll have a motivated group of volunteers that we can draw from to help lead the study.
That's great. We've definitely had people in here saying, want to be part of the next trial. We had someone from Australia saying, can I join even though I'm not in the United States? So there's definitely a lot of interest, I think. And then we are at the hour here, so I know you're super busy, and I will let you go, even though we have a ton more questions. I might send some of them to you that we can answer individually. But I did want to address one more while we're on the webinar, because it came up a few times, and I think people don't talk about it enough, which is sex safe after an aortic dissection?
Great question. And that's something that we do talk about with our patients. Yes, sex is safe after an aortic dissection. If you look at the recommended levels of activity, it is not part of even in the current guidelines, it is not contraindicated. It's not considered a strenuous or vigorous activity that would be dangerous. So we do tell people, it is a challenge sometimes, but it is very important and to say that because there's a lot of misinformation about the safety of sexual activities, and there's no evidence at all that sexual activities are harmful after dissection.
Thank you. Okay, so we will end there for the day. This, I think, has been the most engaged our chat has ever been at a webinar. So I really appreciate you all coming in and participating and sharing your stories and asking great questions. And I think, Dr. Prakash, this just shows you how valuable your work is. We have lots of people saying thank you and that they so appreciate your interest in this topic, because it is such a quality of life issue for our community. So thank you for your time and your work on this. And I hope that we can come back and hear results, both of the aortic stiffness portion, but also of, that we're launching a huge national trial that's home-based that everyone can participate in.
Thank you so much. And it was great to have this opportunity. I'm really appreciative of all the support that JRF and the community has given to our studies. Thank you.
Yeah, happy to do so. Okay. Well, thank you so much, everyone. It was recorded. It'll be posted on our YouTube. I'll send that out to you along with the brochure that is kind of the standard of care that we have. And we will see you at our next webinar. If you had any questions that did not get answered or that we can help with, please do reach out to us. You have my email since you registered for this. We'll try our best. And Bella put it in the chat too. I see she's been answering everyone. So thank you so much, Bella. And we will see you at our next webinar. So thanks everyone and take care.
Bye.